Neurosciences Forum, which is being conducted with Indian Medical Association, Academy of Medical Specialties, Coimbatore branch. I welcome our speakers of the day, Dr. A.V. Subramanian sir and Dr. Srinivas Paramasivam sir for joining this program today. This Neurosciences Forum we are conducting for past 18 months. We are conducting the program every month. We are having one topic by neurophysician and one topic by neurosurgeon. Like that, we are conducting the program. And the peculiarity of this program is that at the end of the program, what we will have is we will have the quiz questions for the postgraduate students, for the benefit of the postgraduate students, and those who are replying promptly are awarded. That's what we are doing regularly, and we are conducting and we are continuing this program continuously. So I welcome in our speakers of the day, Dr. A.V. Subramanian sir and Dr. Srinivas Paramasivam sir for this nice lecture. And this month in the neurology and neurosurgery, what we have is that we have the World Stroke Day is coming in this month. That's why we thought one of the topic may be related to the stroke. That's why Dr. Srinivas Paramasivam sir, we have invited him to give a talk, and Dr. A.V. Subramanian sir. So I welcome both the speakers, and straight away we will go for these lectures. Sir is a senior consultant neurophysician. He is conducting the AVS and Dr. AVS Neuro Clinic at Trichy, and he is a senior consultant neurophysician. He is graduated from Madurai 1990 and MD General Medicine from Nagpur University and DM Neurology from VGIMR Chandigarh 1995. Special training in neuroelectrophysiology. And oration awards are Professor Sivakumar Oration for 2015 and Professor Armagam Oration for 2022 and Dr. R. Sundarajan Oration for 2024. Area of specializations are regenerative disease, the psychoneuroimmunology, and the mind-body medicine. Experience is 30 years experience in neurology in Trichy as a senior neuro consultant. Welcome you, Dr. A.V. Subramanian sir, for your lecture.
Thank you. Good evening, one and all. I thank the Coimbatore Neurosciences Forum, the IMA AMS chapter Coimbatore, and especially the course directors, Dr. Rajesh Babu, Dr. Vikram Muthu Subramaniam, who arranged this CME. And I thought we'll talk on a very practical day-to-day topic which we see in our OPD regularly. We are going to talk about medically unexplained physical symptoms, which we are going to call by the short term of MUPS. And this is a medicine, because we have been always taught to deduce a kind of lesion from the symptoms of the patient, confirm it by imaging, and then treat it. This was how we have been treated. But this is an area where, as you will go through that, you find that you may not have anything on the investigations. So this is a threat to your medical competence. You need to be really good to, distill out the diagnosis from the patient's multiple symptoms. It's quite common. In primary care, if you see, it's around one third of patients can have multiple unexplained physical symptoms. As the patient comes to the specialist, you find that various investigations and evaluations filter it down to around 5 to 10%. Now, the major problem of this constellation of symptoms is that many of these patients who present with this MUPS also have a coexistent anxiety and depression. And the biggest mistake we often do is to assume that all the symptoms the patient is telling are basically psychogenic. This is the mistake that we do, and this is the reason why we are not able to reach a diagnosis. You might have, if you remember our MBBS days in the general hospitals, you'd find that many times this AN, anxiety neurosis written, some Alprax will be given for these multiple unexplained physical symptoms. The reason is because we didn't have the concept, we didn't have the kind of concept that this separate entity by itself, and we were assuming that the entire symptom constellation is due to anxiety or depression. Common symptoms are usually musculoskeletal pain, ENT symptoms, abdominal pain, gastrointestinal symptoms, fatigue, dizziness. So you're at regular OPD. It's a busy OPD. You're already out of time. You're late by 2 hours. And then a patient comes, he complains. So you say, what is the problem with you? What do you have? And then his first complaint, he says headache. And then you ask various relevant questions for headache. And that's inside your mind. And then you plan, okay, let's do a CT scan, let's do blood tests, or let's do MRI or something like that. And then he says, I have a neck pain also. And then you say, okay, fine. So we'll investigate the neck pain along with the imaging that we are planning for the head. And then he says, there's a right lower limb big toe pain. Oh, then you'll have to probably think of the spinal cord, the entire spinal cord. Then he says, the left foot numbness. Okay, now we are looking at a longer area. You'll have to scan the entire spinal cord. And then he says, the right abdominal fullness, which for a neurologist would be looking at the dorsal spine. Then he says erectile dysfunction, then L1, then he says constipation, and then finally he says poor sleep. So by the time he tells all these symptoms, you have lost track because you started with headache and you had a kind of diagnosis in your mind, and then so many symptoms then fall like the water into the river, and then you're not able to reach a proper diagnosis. So what is this MUPS? MUPS are physical symptoms that prompt the sufferer to seek health care, but they remain unexplained after an appropriate medical evaluation. And by evaluation, we mean investigations and examination. These are quite persistent bodily symptoms for which adequate examination does not reveal any sufficient explanatory, structural, or other specific pathology. So you have symptoms, but nothing coming out on the investigations. So you have acute form, subacute form, chronic form. The chronic forms are the most common. So what happens is the doctor is not trained to distill out the diagnosis from the multiple symptoms that the patient is telling. And sometimes the doctor is at a loss to explain. And the patient asks him, sir, what do you think is my problem? And then sometimes some of the doctors tend to, give a diagnosis very early just to satisfy the patient. And then they go on a wrong track. So there's a lot of extensive suffering for the patient. And here I'd like to highlight a point that the suffering of the patient is not imagined. He doesn't fake his symptom. He doesn't manufacture his symptom, he or she. The symptoms are real. That's one very important point which I like to drive home in this talk, is that in MUPS, the symptoms and the suffering are very, very real. They are not fake. They are not manufactured. They're not in the mind of the patient. What happens is because of these multiple symptoms, there's often a doctor-patient conflict. The patient is not happy with the doctor's explanation. The doctor also is frustrated. Anytime the doctor would like to have a right MCA stroke, there is an infarct on the MRI, and then you treat. So that kind of cases, the doctor is very happy. He's not happy with these kind of cases where they come with some 10 symptoms, of belonging to 10 different systems or different parts of the neuraxis. Then what happens? Some patients mistrust happens. Then there is a mutual doctor-patient connection. It's a very difficult area of medicine to practice. If you get a lot of cases of this MUPS, there is a very high risk that you might get sort of flummoxed, very fed up with practice. You might even think of an early retirement. And what happens is that the bane of our era is the specialization. There was a time when there were very good MDs who could, take care of all the specialties together. But then now you have specialists, and the specialists like the cardiologist or the neurologist, he does tests pertaining to his specialty, and then they turn out to be normal. And the cardiologist tells the patient that, my tests are normal. You do not seem to have any of my diseases. That is, for example, if you take a cardiologist as an example, my cardiological tests are normal. I don't think you have any cardiology problem. I think you better go back and see your GP, because I don't seem to have any problem in my field. Sir, I've already gone to my GP. That's the usual thing. Then he says, oh, if you still have a problem, then I think you should see a psychiatrist. So at the end of the day, the patient's problem is not solved. So the doctor must be very careful not to tell a patient that nothing is wrong, because this is not the case. Actually, the tests are normal, but it is not that the patient doesn't have any. So telling the patient that nothing is wrong is actually not the right way to deal with MUPS. The symptoms that brought the patient to the doctor are actually very real. We are not able to find the cause with the available investigations that we have. So the doctor should try to explain the symptoms in a simple way, which the patient can understand, or possibly, get to explain the patient symptoms in a way the patient can sort of logically try to understand. Avoid blaming the patient, avoid being judgmental, and work with the patient to develop a symptom management plan. For example, let's take this lady who presented with a left upper limb numbness. So any doctor will be looking at the right cerebral hemisphere. Numbness means most probably thalamus. But then you do a CT scan, it's normal. You do an MRI, it is normal. Every investigation is normal. So this lady is labeled as hysterical sensory conversion disorder. Hysterical sensory conversion disorder, because there is numbness. She comes with the numbness, but CT scan, MRI, everything is normal. But if you do advanced tests on this patient, like you do a PET, you do a SPECT, you find that there is a lesion in the right thalamus at a functional level. So you can see here in this diagram, there is a lesion in the right thalamus at a functional level, but there is no structural lesion picked up on the MRI. So because the CT scan and MRI are normal, it may not be right or proper to label the patient as a hysterical conversion reaction, because further tests may actually show you that actually the patient's symptoms are emanating from a lesion which is more physiological or functional, but not anatomical or pathological. Now, this is the basis of this sentence is the basis of this disorder. So you may have a physiological or a functional basis for the symptoms, but you may not have an anatomical or a pathological kind of thing, or radiological, which may show up on the tests. Patients with MUPS, for example, there's a housewife with multiple symptoms. She may say that I'm not able to cook, I'm not able to stand. There are 3-4 people in my house, and I have to make some 12 or 50 dosas. I can stand. So she has stopped cooking. So the family gets food from outside, or they have engaged to cook. So there is a high level of disability which the patient reports. But when you examine them, they are actually not that disabled. She might say that she can't stand for even more than 3 minutes, but her spine is okay. There is no lumbar canal stenosis. She can stand, and there is no reason why she should not stand. But she will report a high level of disability. And to mask her anxiety and depression, they minimize their psychological distress. So they minimize their psychological distress, maximize their physical disability. This is a very important component of MUPS. Now, if you tell the patient that I'm not getting anything on the tests, I really don't know what you're having, because every test is normal, they may actually, some of them may become sort of combative, confrontative. They may say, sir, I have come to you with numbness, and you say there's nothing, but tomorrow if I have a stroke, then I don't know, I will hold you responsible, things like that. Some people may question your competence indirectly. They may say, sir, have you seen patients like me? I mean, are such patients coming to you? Like, how many of patients like me you have seen? How many, have treated? How are they doing, etc. One of the important reasons why patients is a wrong attribution of the symptoms. So I'm giving 3 examples. The first one is a normal person. The second is a depressed person. And the third is a patient with MUPS. So for example, there is a symptom called tiredness. So a person says, I'm tired. So the normal person says, sir, I'm tired, but possibly I worked very hard last week. I didn't have rest. It was severely hard, schedule I had, and no rest at all. So probably because of that, I'm tired. That's normal. The person with depression may say, so my father died 2 months back. Then, I had a series of tragedies, and I am depressed, and I think that depression is causing the tiredness. So that's a typical patient with depression. But the patient with MUPS will say, I think, sir, my muscles are infected with the virus which I contracted during the course of a febrile episode. So I had fever 3 weeks back, and then that virus has entered my muscles, and now I'm getting tired. Now, this is the wrong attribution which the MUPS person does. And it is our job to actually remove this kind of a misplaced kind of attribution and then re-attribute the symptoms later. We will be touching upon that later. Now, this is a topic which is not confined only to neurology. MUPS in virtually every specialty. So, for example, if you take urology, there are patients coming with chronic prostatitis, coming for months and years, urethral syndromes. In gastro, you have irritable bowel syndrome, gastroesophageal reflux. Then in cardiology, you have this typical atypical chest pain, mitral valve prolapse syndrome. Orthopedics, you may find people coming with low back pain and the MRI not showing any significant cause to explain the kind of pain. In dentistry, you may have temporomandibular dysfunction going on for months and years, months and years. Gynecology, you may have chronic pelvic pain, no cause found. Premenstrual syndrome, no cause found. Rheumatology, you may have fibromyalgia, myofascial syndrome. ENT, you may have an idiopathic tinnitus. Everything is normal. Internal medicine, you may have a lot of these MUPS coming in different forms, like idiopathic syncope, chronic fatigue syndrome, tiredness, etc. So this MUPS occurs in every specialty in the form of multiple symptoms, but nothing turning out on the investigations. So you can have a heterogeneous picture, extremely variable, and significant overlap. For example, you can have an organic disease and MUPS. For example, a person may have a myocardial infarction, diabetes, hypertension, and yet he may have MUPS. So it is not that they are exclusive. So a person will have an organic disease and also have MUPS. And many a times what happens is that, for example, a person may have neuropathy, diabetic neuropathy, and he may have MUPS. What he will do is he will amplify the symptoms. He will amplify. He will say, my burning is not reducing. My burning has ascended up to my chest. So from here itself, I'm getting the burning. Whereas in a diabetic neuropathy, you get burning more in the distal extremities or rarely in the trunk, but never, in the head, neck, and the entire body. But they will amplify their symptoms. So that means that in neuropathy, you have an MUPS component also. But before you decide that is MUP, please look at whether some of the drugs are causing the symptoms. So this is a very important part because most of the patients are on different drugs. Look at the drugs, whether a diuretic causes cramps or some, pain in the abdomen is due to a renal stone if the person is on topiramate or something. So look at the drug history, improve your pharmacology, try to see if some of the drugs are causing the symptom and you probably do not know that this drug can cause this. So that's one area we need to look at very carefully. So once you get into the treatment of that, then you will have to acknowledge an important point, that is uncertainty, because you really don't know what is the problem. Because so you will have to first acknowledge that there is an uncertainty, and the relation between the psychological distress, personality, MUPS, distress, disability is very complex. It doesn't follow a single linear relationship. It is not that, there was a court case yesterday and the symptoms started today. It is not such a linear kind of thing. The very complex relationship. So clinicians should actually acknowledge uncertainty, elicit, validate, and to some extent adopt the patient's perspective. So once the patient's perspective is understood and then adopted, the alliance is formed. That's called a therapeutic alliance between the patient and the doctor. Otherwise, the patient will leave you. If you do not have the proper alliance with the patient, so that's called a therapeutic alliance, happens only when you adopt the patient's perspective. MUPS are associated with a lot of psychosocial distress, psychiatric disorders, decreased quality of life. They keep on coming to the emergency, increased healthcare utilization. They keep on phoning you. They keep on giving you WhatsApp messages, depression, anxiety, mood disorders, etc. And MUPS, many of the symptoms can happen because of this anxiety, depression. For example, you may have fatigue due to depression. You may have tremor due to changes in sleep, palpitations due to autonomic dysregulation. So many things can happen because of your anxiety and depression. Rarely, they may even have somatic delusions that, there is something wrong with their stomach, or there's something wrong inside their mouth, or something like that. So these are some predisposing factors: heredity, chronic disease, early life adversities, chronic distress, mental illness, chronic disease. Now, in hereditary cases, people are looking at genes, and they have found out that some of the genes, some of the polymorphisms may be associated with a hereditary MUPS. And the precipitating factors are usually an acute fever, an acute illness, acute trauma. There could be psychosocial stressors, acute psychiatric disease, and epidemics. The COVID saw a flurry of cases of MUPS after the epidemic went off. The next thing that happens in MUPS is perpetuating factors. These patients don't get all right. They have symptoms for years. Two days back, I had a patient who had symptoms for 22 years. 22 years. And that's because of perpetuation of symptoms. And why the symptoms perpetuate is because there are the chronic illness, harmful illness beliefs, misinformation. Some of them may have this compensation at work. Nowadays, people want work at home. And some of them could be using these symptoms to not attend office and sit at home and do the work at home. Poor social support, deconditioning. Some of them may not be exercising. So if their body's physical deconditioning has happened, they might be getting a lot of body pain, body-related symptoms, and negative health habits. Now, this is a cycle which often repeats in MUPS, wherein a person has a stroke. For example, a person has a stroke and is recovered, and he has an increased mental focus on that episode. So that creates anxiety. And whenever he gets any kind of numbness or pain or anything in that side of the body, immediately the anxiety increases, the physiological arousal happens, causes increased muscle tension, back tightness, muscle cramping. Again, he feels he's going to get a stroke. He lands up at 2 a.m. at your emergency, saying that I'm getting a re-stroke. The same thing happens in an MI. So the person gets an MI, and then he is so much focused on that, the persons with MUPS, that there is an anxiety buildup. If there is a kind of chest pain, which may be totally non-cardiac, but it still builds up the anxiety, physiological arousal, again causing muscle tension. Again, he feels he's going to get another attack. Again, he comes up at 2:30 to your casualty, telling that, I am having chest pain, probably I'm getting an attack. So this kind of thing keeps on happening in MUPS. So why does this MUPS happen? So basically, the hypothesis is that every organ in the body is connected to the brain in a two-way communicating system. And there is a kind of corticofugal inhibition which happens in the diencephalon, the brainstem, which filters irrelevant bodily stimuli. So, for example, there are a lot of bodily stimuli going into the brain, and the brain actually does a kind of inhibition, filtering out the irrelevant kind of sensation and only sending in the relevant kind of bodily stimulus. So here, there's a hypothesis that there is a central kind of sensitization where there is a reduced corticofugal inhibition, so that all kinds of irrelevant bodily stimuli are not getting filtered, and they go into the brain, and the patient starts reporting all these symptoms. A dysfunction of the secondary somatosensory area in the brain, a hypersensitivity of the limbic system, all these are hypothesized as possible etiological factors. People are also looking at the ACC, anterior cingulate gyrus, which has a role in the emotional regulation of pain memories, and that there could be a dysregulation there, or there could be an amplification of the normal dysregulation. So these are all theories to explain why this MUPS happens. Now, MUPS is called by different terms by different doctors. So some people call it fibromyalgia, some people call it pain syndrome, functional syndrome, somatoform disorders, somatization disorders, things like that. There are a lot of terminologies, a lot of patient is confused. So you tell him that you've got a somatoform disorder. He tells you that, sir, but that ortho person told me that I've got fibromyalgia, or that particular ortho person told me I got a lumbar disc disease, etc. So there's confusion in the patient, in the doctor. There is a disease overlap. There is a coexistent disease also causing problem, and many times a second opinion confusion. So person goes to multiple doctors, and one doctor does a MRI of the lumbar spine, and there is a small disc there, which is not causing the symptoms of the patient, because symptoms of the patient are from head to foot. So a lumbar disc cannot cause a symptom in the head or neck, but the doctor tells him you've got a lumbar disc, you may need surgery. And then the patient accepts that as the diagnosis. And then he says, sir, I'm a patient of lumbar disc prolapse. Whereas he will be reporting of a pain in the head, neck, which cannot be explained by a lumbar disc. So many times multiple opinions tend to actually make the picture more and more complicated. So when you deal with a patient with MUPS, the first thing is you have to be humble, honest. You have to be honest that you have to tell the patient that doctors often see patients with symptoms like you, and we do not know the exact cause. And patients welcome this honest kind of expressions, provided that they are made to understand the medical certainty involved. But only this honesty will not do. So just being honest is not enough. You will have to also tell that you are experienced. You have seen many patients. So you can say that, I have seen many patients like you with unexplained symptoms similar to yours, but they are doing well with treatment. So that's a kind of clinical experience. And you are also throwing in a hope. So you have to also give them a hope that, science has shown that though we don't know why these things happen, we can work together and we can make you feel better. So you start with a kind of honesty that we really don't know what is happening, but then I have seen many patients, they are doing well, and then science is also helping us to make your situation better. And they should also promise action. So we say that no matter what we decide to do, let's continue to meet on a scheduled basis until we agree that, things are effective. So clinicians should foster a collaborative physician working style. So if we work together, we can make a positive impact. Do not be dismissive. Never be dismissive for MUPS patient, because for the patient, the symptoms are the main troubling symptom. That is what is really troubling him or her. Do not be dismissive at all. Do not be patronizing also. Have empathy, not sympathy. Empathy means you put yourself in the shoes of the patient. Look at the patient's issues from her or his viewpoint. That's called empathy and not sympathy. Sympathy means you just say, I feel very sorry for you. That's all. But you don't do anything. So have empathy and destigmatize distress. So you tell them that, symptoms like yours are often distressing. I know that they can affect your relation. I know that it can affect your morale. But then, your mental health care can improve these issues. So like this, you will have to empathetically get into a very strong therapeutic alliance with the patient and try to do good for them. So this is an important slide. What helps in MUPS, what doesn't? So what we'll look at first, what doesn't help to. So it doesn't help to focus exclusively on a diagnosis. So person comes with 10 symptoms. Please don't try to create or make a diagnosis in the first visit or the second visit itself, including all the symptoms. Never try to do that. Never focus and try to immediately diagnose, to immediately reach a diagnosis in the first visit and write it down on the paper, your prescription. That's not necessary. Most of the time you'll go wrong. But you should give a diagnosis, but that will get revised in the future visits based on what the investigations throw up. Never dismiss the symptoms as normal and treat symptoms with drugs, whatever. I mean, it's not that suppose person comes with neuralgic pain, you carbamazepine, gabapentin. I mean, it's not like that also. And never assume that you know what the patient wants. Never assume. You always ask them, what do you feel is troubling you the most? And don't judge the patient. Don't be critical of their behaviors. Most of the time in female patients, the husband is often very critical because he's fed up with this MUPS. So he's already critical. If you are also critical, they'll simply leave you and go away. And be careful not to oversimplify the whole thing. Don't just say that, you just have acidity and I think the acidity is the cause of everything. So don't oversimplify also. The MUPS is not so simple. It is a very complex disorder. And don't ignore or miss psychological cues. Sometimes there are some psychological cues which will give you a diagnosis that yes, this is, but the patient will say that, sir, whenever I'm getting stressed, the symptoms tend to increase. And that will be a psychological cue. And what helps is to focus on the symptoms. So look at the most troublesome symptom and look at how much their functioning is getting affected. Match your explanation using their own words. Discuss the possible test results, the implication, therapeutic trial, side effects, share the decision, listen to what they want. Listening is very important in MUPS, and acknowledge the importance of the patient's views and her or his circumstances. Allow time to make connections. Sometimes in a single consultation, you may not be able to make a strong connection. And be reassuring that a serious cause appears unlikely. For example, the person has done some basic investigation. There is an ESR, which is normal. There is a CRP, which is normal. There is an alkaline phosphatase, which is normal. You can always say that, okay, these investigations are normal. I think we are not dealing with a serious problem. However, we'll keep that also in mind, we'll keep an open mind. Before concluding that the patient has MUPS, it's very, very important that you have to rule out treatable disorders. You should not miss out a vasculitis, miss out a connective tissue disorder, miss out an SLE. So a good and reasonable workup is very, very important before you think that this person has MUPS. So do a good workup: systemic illness, vasculitis, connective tissue disorders, multiple sclerosis, thyroid disease, endocrine disease, substance use, alcohol use, HIV, TB, nutritional disorders, and the relevant investigations based on the symptoms. Rule out mimics. Only when these investigations turn out to be normal, then you start thinking it is MUPS. In a workup of MUPS, focus first on the patient's chief concern, physical symptoms, and among the physical symptoms, which is the symptom which troubles you the most. So try to relieve the patient of that symptom, because that is what is troubling them the most. And while listening to this, strive to assume the patient's perspective. That's very important to secure their cooperation, enhance the empathy and rapport, and understand the patient's symptoms in a biopsychosocial framework. It is not just a linear kind of thing that you have a chest pain, you have an ECG, you have an echo, everything showing MI, and then you send them for a thrombolysis. It is not so simple here. So when the patient comes to a GP, this is called the primary care approach. You do the relevant workup for the symptoms and start them on symptomatic therapy. Please emphasize on maintaining normal activities. So somebody stopped cooking, somebody is not working or taking rest. Please discourage them from taking rest. Try to say that even if you have symptoms, keep on working. Try not to get into a sedentary or a physically deconditioned state. Keep on, try to work as much as possible. Too much rest should be discouraged. Sometimes some doctors tend to tell the patient that why don't you take some full rest for another 3 months and then we'll see how things work out. I think that advice is wrong in MUPS, because once they do that, they mentally, physically get deconditioned. It'll be very difficult for them to come back to the normal routine. So too much rest should be discouraged, and even if allowed, should be short and sweet. Maybe rest for 1 week or a few days. Supportive, caring, respectful, empathetic relationship between the doctor and the patient. Inquire about specific fears. Most of the time, the patient has a fear of getting an hemiparesis or getting a heart attack or dying because someone in the family has died prematurely, or someone has been getting stroke. Someone got a young MI and died. And sometimes these fears are not expressed by the patient in the first OPD. So try to look at if there is a fear in the patient's mind and tell them that your disease is not, you're not going to get a stroke, you're not going to get an MI, or I don't think that you're going to die prematurely. Such a thing is not there. And once you tell that anxiety goes off, they become so relaxed. Allow time for the patient to ventilate their frustration. Information, reassurance, education, problem solving, and try to improve their support systems. Try to mobilize whatever support system is possible. Husband, brother, uncle, children, son, daughter, whoever is available, try to improve their support system, because that is what they want. Sometimes you may not be able to do anything. Sometimes a severe MUPS, you may not be able to do anything, but just being there helps. Just being there. MUPS is about the doctor having a number of hypotheses, and many patients just need reassurance that you don't have a serious disease, you're not going to die, you're not going to get a stroke. I think you'll get better, you'll get better. So just being there, even if you're not doing much for the symptom, just being there itself helps. So most people in MUPS who see their GPs will improve even without any specific treatment if the GP is able to give an explanation for the symptoms that makes sense to them, removes any blame from the patient, generates ideas how to manage their symptoms. But when MUPS becomes chronic, then you need a psychiatrist consult also. So please remember the statement: if MUPS is acute, you can manage. But if the MUPS becomes chronic, you definitely need a collaboration of the psychiatrist. Have a psychiatrist who is an expert in the somatoform disorders, because such a person only can help. Every psychiatrist may not have enough experience in dealing with somatoform disorders. Now, as soon as you say psychiatric referral, the patient will say no. And no, I don't have any psychiatric problem. Or he will go and come back and say, sir, his medicine didn't suit me, and he will not take the medicines. So tell them that this is just an opinion. We are just getting an opinion, and we are going to get his suggestions, and you're going to come back to me again, and we are then going to see what are the medicines we are going to write. So the patient shouldn't feel that you are trying to sort of send them away from your care, like never come back to me again, go to the psychiatrist and then get lost. It is not that kind of sending off. It's an important complementary treatment, and a simple reassuring step is to tell the patient to come back to you and show you the psychiatric instructions. So you tell them that I am the person who's going to treat you. We are only trying to get a collaboration from the psychiatrist and take his input. And if you do that, then patients will not be so resistant to psychiatric opinions. So allow sufficient time, acknowledge the reality. This is very important. We should acknowledge that their symptoms are real, and that's many times we don't do that. Recognize that their symptoms are not imaginary, and then take an exhaustive history to allow the patient to feel understood. So psychiatrists who deal with somatoform disorders often spend 30 to 45 minutes listening only to the history, and the patient comes back and tells that, "Sir, ningo or alta amchingu, sir, you send me to a psychiatrist." He spent 40 minutes, the doctor, I couldn't believe in such a busy practice, 40 minutes he devoted to me. He's really a nice doctor. And the time that you give to the patient, that is very important in MUPS. You may charge more because you're spending more time. Please charge more. That's okay. But give them some time to ventilate all their symptoms. And ask the patient about their past experience of contact with the medical system. For example, they might have gone to an emergency. They might have gone to another ortho, another neuro, or some. And sometimes that experience may not be too positive. So keep that in mind that you don't repeat the same kind of experience at your side. And acknowledge any kind of labeling or stigma. Don't label them as a psychiatric problem or stigmatize them. So many patients don't like going to a psychiatrist because they say that, "Sir, I've got numbness, I've got pain, and you're referring me to a psychiatrist. I don't have a mental health problem. I'm coming to you for physical problems." So very difficult for them to understand that this can happen due to a mental connection. And that is where you have to slowly tell them that there is a mind-body connection, and that is probably operating in you. And the patients do not understand that depression and anxiety can have an impact on MUPS. Secondly, they get stigmatized. So once you go to a psychiatrist, immediately the entire family will say, "Okay, fine. So this lady is a psychiatric case," and they don't want that stigma. And they have chronic pain or chronic physical symptoms which actually distract them from their mental health problem. They may have mental health problem, but because of the predominance of the pain and physical symptom, they tend to sort of minimize their mental health issues. So it's very important to keep a very open mind about any disease which may come up in one of these investigations. So provisionally, you can tell them that we think you have MUPS, but we still are keeping an open mind because most of your investigations are negative. So in an approach to MUPS patient, generally we say CARE MD. CARE means consultation, psychiatry, consultative collaboration, assessment, evaluate for medical psychiatric diseases, or regular visits. If someone is disturbing you on the phone or on the WhatsApp or coming frequently to the emergency, then you schedule short follow-ups, like every 10 days, every 15 days, tell them to follow up at your OPD so that you are able to make them better, then they will stop disturbing you so much. So stress coping, try to cope their stress rather than cure. Empathy, medical psychiatric interface, and avoid comments such as "there's nothing medically wrong with you. You don't have a medical disease." Never tell that, because this is a medical disease. Never tell them there's nothing medically wrong with you. And most important is do no harm. Many a times, some investigations might throw up some unrelated disease, like there could be a solitary gallstone without cholecystitis. There could be a calcified lesion in the brain, absolutely not connected to their symptoms, or there could be some kind of a absolutely unrelated thing. And don't pick that up and make it a big issue and send to us a specialist. And so the patient will sometimes think that that is the cause of all their symptoms, and they will go on a wrong track totally. So in MUPS, you don't try to eradicate all the symptoms. Try to restore a normal functioning. It's very important that they remain functioning so that the family is happy, their responsibilities are taken care. Manage the disorder, not the symptoms alone. Try to give simple medical explanations. Educate the patient that these symptoms do not always mean serious disease. Psychotherapy, you can try antidepressants, TCAs, SSRI, SNRI, and Opipramol. This is a drug which we are going to see in greater detail in the next few slides. Exercise regimen, physiotherapy to keep them physically conditioned, cognitive behavior therapy, mobilize all the support system, good collaboration between the various consultants. So this is in short the care of MUPS patients. Now, MUPS is now labeled as somatoform disorders. This is as per the DSM-4 criteria, which tells us that this MUPS comes under somatoform disorder, also known as multi-somatoform disorder. But in the DSM-5 criteria, which is the more later version after DSM-4, this has renamed it as somatic system disorder, SSD. So this MUPS is now called as somatic system disorder, SSD, and there are two subtypes, one having pain and one having somatic symptoms. So you have the pain subtype and the somatic symptom subtype. So what you have been talking so far is now called as somatic system disorder, SSD. So this is just a timeline of the terms which were used since ancient times. You have the Briquet syndrome, 1859, somatization disorder, functional neurological disorder, and then the terms are slowly changing, and the present term is somatic symptom disorder. So let's look at this drug, which is the main drug for these patients. Now, Opipramol is structurally similar to imipramine, but it is not a tricyclic antidepressant. So this is a very important statement. Its structure is similar to imipramine, but it is not a TCA because it does not inhibit the neuronal uptake of norepinephrine or serotonin. So this is a dibenzapine group, and it was used in Europe for a long time as a substitute for benzodiazepines because Opipramol does not have any risk of drug dependence. There is no drug dependence or addiction. So in Europe, they were using it as a substitute for benzodiazepines in anxiety disorders. In India, November 2010, it was approved for treatment of generalized anxiety disorder, GAD, and somatic disturbances. It is a potent sigma ligand agonist with high affinity to sigma 1 and lower affinity to sigma 2. Sigma receptors are found all over the brain, and they are very important in the regulation of various neurotransmitters like 5-HT, dopamine, norepinephrine, serotonin, etc. So Opipramol is an atypical anxiolytic, atypical antidepressant. So this is a very important statement. Please remember, this is the drug of choice for somatoform disorders. It is a path-breaking sigma 1 receptor agonist indicated for the treatment of somatoform disorders. Does not inhibit reuptake of non-adrenal serotonin. This activation results in dopamine release, 5-HT release, calcium efflux. It is rapidly absorbed in the GI tract, reaches peak levels in 3 hours. Bioavailability is 94%, protein binding 91%. Elimination is mainly by the renal route. So if you have a kidney disease, you need to reduce the dosage. The dosage is 50 milligram TDS given thrice a day. Can be increased to 100 mg TDS if felt necessary. Not recommended in children, not to be used in pregnancy or lactation. Generally a safe drug, mild sedation, mild anticholinergic side effects, but no major side effect. There is no evidence of dependence. It is weight neutral. So it has a lot of positives. The contraindications are like any other antidepressant, obstructive uropathy, glaucoma, delirium, cardiac conduction disturbances. I always do an ECG before starting Opipramol to look for evidence of any kind of cardiac conduction problems. There we tend to avoid Opipramol. Epilepsy, chronic renal failure, alcoholism, concurrent usage of MAO inhibitors. So to summarize, Opipramol is the first psychotropic drug with proven efficacy in somatoform disorders. It has antidepressant and anxiolytic properties. It's effective for various forms of somatoform disorder, as effective as alprazolam or escitalopram in GAD, better tolerated, effective, well tolerated, no dependence, no misuse potential, no addiction, no dependence. So to summarize the whole talk, so what we are basically doing is to re-attribute the symptom. We started off with the wrong attribution. The patient telling that a virus has entered my muscle and the muscle is causing pain and fatigue. So we try to re-attribute the whole symptoms and reframe the hypothesis. So treating MUPS is re-attributing and reframing. So make the patient understand that their initial understanding of the disease was wrong, and then try to re-attribute and reframe the whole picture. So acknowledge distress, elicit the patient's perspective, focus history taking, physical examination, reassure the patients, discuss alternative interpretation of the symptom, prescribe medication, coping strategy, stress reducing strategies, individual's responsibility, and give a specific appointment. So this is known as the 10-step reattribution protocol. Expert. A lot of psychiatric interventions. This is done by the psychiatrists from their side. And this is one important thing that's coming up in the treatment of MUPS, the importance of pleasurable private family time. Now, this is coming up as a healthcare intervention that we are not spending time with the family, and we should encourage the patient to spend pleasurable private family time. So the husband, wife, and the children, they go somewhere, or they have their own private time somewhere, and they relax over a weekend or some holiday. It's very, very important. Yoga classes, meditation, short vacation, nature walks, etc., etc. So key points is patient wants to be taken seriously, show that you believe them. Doctor can make a difference to the patient's well-being even when their symptoms are unexplained. And sometimes the only therapy needed may be the strength of the doctor-patient relationship, continuity of care, and the long-term relationship. Be very explicit about your thoughts, your uncertainties, your expectations of referrals to specialist care. Proactively communicate with other clinicians. As Shakespeare said long, long back, this statement is relevant even now, centuries later. Thank you very much for a patient hearing. Thank you.
The second speaker is Dr. Srinivasan Paramasivam, sir. He is the head of the endovascular surgery and at Apollo Hospital, Chennai. He is a senior consultant and neurosurgeon. He is graduated from Madurai Medical College, MD Doctor of Medicine, confirmed in the New York State Educational Department, New York, USA, and MCA Neurosurgery from Madras Institute of Neurology, and MRCS Edinburgh, elected as a member of Royal College of Surgeons of Edinburgh in 2006. Fellowship training in neurointervention at University Hospitals, Switzerland. Fellowship in endovascular neurosurgery, St. Luke's, Roosevelt Hospitals. He currently works as a senior consultant neurosurgeon and head of the endovascular surgery at Apollo Hospital, Chennai. He has a membership on our publications. Paramasivam sir is a member of 7 medical organizations, international and national level, and executive member of the Society of Neurointerventional Surgery and Tamil Nadu Association of Neurosurgery. He has published more than 35 peer-reviewed scholarly articles in leading journals. He has authored and co-authored 12 book chapters at various topics. He has served as a principal and co-investigator for multi-center clinical trials. I welcome Dr. Srinivasan Paramasivam sir to give his lecture on the recent trends in the stroke management.
Good evening, everyone. And it is my pleasure to be here amongst you at the Neurosciences Forum with Indian Medical Association, Academy of Medical Specialties, Coimbatore branch. I particularly thank Dr. Vikram and Dr. Rajesh, who are the course directors, and for giving me this opportunity, as subsequently this month after Diwali comes the World Stroke Day. To commemorate the World Stroke Day, I've been asked to talk on a topic which is a game changer in the management of acute stroke over the last decade. And we have evolved significantly with the management of acute ischemic stroke, especially with the large vessel occlusion. And no other specialty has transformed so much in a very short time with regards to the management paradigm. Luckily, I have been part of this change. I will just share some of my thoughts and views on how the stroke management has evolved and what we do today, just to give you the concepts of acute stroke intervention in today's world. We all know that stroke is a sudden dysfunction of the affected part of the brain due to ischemia or due to hemorrhage. And this happens all of a sudden like a bolt from the blue. And this has been explained more than 2,400 years ago by Hippocrates. But there has not been a significant progress in terms of management or treatment. Among this, more than 80% of the strokes are ischemic stroke, which may be a small vessel occlusion, like I've shown, or maybe a big vessel or a large vessel occlusion, like the ICA, MCA, ACA, occluding, causing a major stroke. and this constitutes about 80%, and the hemorrhagic stroke only constitutes about 20% of all the strokes. When a large vessel is occluded, what exactly happens is that with each minute passing by, 1.9 million neurons die. With each hour, about 120 million neurons, and the brain ages much, much faster at a rate of about 3.6 years with each hour that passes after the large vessel occlusion till a complete infarct happens. So time is brain, which means time is extremely important in terms of treatment paradigm. So when an acute stroke hits due to a large vessel occlusion, what exactly happens is there is a core or an area which is totally infarcted, and surrounding which there is a penumbra, a zone that is still surviving, but it is at the verge of death because of decreased blood supply. And through leptomeningeal collaterals, which I'll be talking about, the tissue is just surviving. If we don't do anything about it, this core will expand over a period of time and it will destroy more tissue. This penumbral zone is what we are trying to treat. The core, which is already dead and gone, we will not be able to revert back, but the penumbra is what we are looking at. So this is a difference between the time and the tissue window. So what exactly keeps this penumbra open is the collaterals. Like we have the skull-based collaterals, which is the circle of Willis. We have leptomeningeal collaterals. The leptomeningeal collaterals are the collaterals between ACA and MCA, ACA and PCA, and MCA and PCA, as well as in the posterior circulation between the superior and inferior cerebellar arteries. You have this collaterals which supply the cortical tissue, and they kick in. Luckily, some people have very good collaterals, whereas others don't. For example, a patient with an M1 occlusion, if they have a collateral like what I have shown here, coming all the way back to fill the MCA backwards, these patients will sustain or survive their brain for a very, very long time. And we go and do a thrombectomy, they do very well clinically. So this is what we aim to look at during our first angiogram. How do these collaterals behave over a period of time? And that leads to the tissue which is salvageable. The salvageable tissue over a period of time, say from 6 hours to 24 hours, progressively declines. First 6 hours, there is a significant amount of brain tissue that can be salvaged. And we have moved on from time window to tissue window, and early time is a surrogate marker for penumbra. As time passes by, what happens? This penumbral zone significantly reduces and the benefit of thrombectomy goes down. So practically first 6 hours is still considered to be the better period for doing mechanical thrombectomy. And for all patients who come within the first 6 hours, we do the basic imaging, and then we try to do thrombectomy in all patients when there is a large vessel occlusion that is demonstrated. For patients who come later, beyond 6 hours, up to 24 hours, we do advanced imaging with perfusion scans. This perfusion scans will tell us what part of the tissue is already infarcted and what part of the tissue is at risk. The perfusion deficit versus the core is what we are looking at, which I will elaborate a little bit as we go along. A patient first coming within the first 6 hours, what we do is we do CT brain with CT angiogram. In the CT brain, you may see something like this. Hyperdense MCA sign is what you may be looking at. And then in CT angiogram, you will look at where the clot is as a block. And then you will also look at, in a polyphasic CT, you will also look at the amount of collaterals. So CT with CT angiogram is extremely useful in deciding the need for intervention and for planning your treatment, because it gives you a lot more information. In a patient who has already had a stroke in less than 6 hours, when you do, these are the following signs you may see. Already the infarct may be well established, like in this case in a PCA territory, or in a disappearing basal ganglia sign. This you can see here, compared to this side, the basal ganglia looks hypodense and the gray-white differentiation is lost. And loss of insular ribbon, there may be subtle signs like loss of insular ribbon can be visualized. The aspect score in a CT scan is extremely useful in predicting the outcome of mechanical thrombectomy. It is scored between 1 and 10, ideal to have more than 6. The more the score, the viable the area is, the lesser the score, less viable the area is. In current era, even for less than 6, we are doing mechanical thrombectomy. But in the past, we did mechanical thrombectomy only for patients who did not have any significant infarct. So moving on, the CT angiogram is extremely useful in identifying the site of occlusion, the length of occlusion, the collateral circulation, especially the multiphasic CT angiogram is excellent for collateral estimation. And we also have additional information about the aortic arch, carotid bifurcation. So planning the treatment becomes extremely easy when we have a CT angiogram. If a patient comes beyond 6 hours, as I told you, if the patient comes much later, what we do is we need to do a perfusion imaging. It may either be a CT perfusion or a multimodal MRI, which includes the perfusion imaging as well. In CT perfusion, we look at various parameters like cerebral blood flow, blood volume, mean transit time, and time to peak. The time to peak is extremely important, which tells us the amount of collaterals and the compared to the core, which has a blood supply of less than 30% of the normal blood supply, and the critical Tmax area, we compare and then decide which patient will benefit. In general, CT perfusion is difficult for interpretation. It needs a radiologist who is very well experienced in seeing the CT perfusion time and again, and the quality of the imaging should be good for identifying the tissue at risk. Whereas MRI is relatively much easier because with MRI, you can do a multimodal imaging, which includes diffusion weighted image, ADC map, which includes mean transit time, flare image, and gradient echo image. Generally, we look at diffusion versus flare. If there is a change in the diffusion and the flare is not matching, then the tissue is viable. We also look at perfusion imaging, that is the mean transit time. The perfusion and diffusion mismatch also tell us that there is a viable tissue, and along with that, the gradient echo will tell us if the clot is a red clot, which will appear as black. And we also get the bold sequence to look at the vessel occlusion. So multimodal MRI, which only takes about 20 minutes to do, if it is readily available, then gives us a lot more information, and the information is superior. For stroke imaging, we today have a rapid AI, which is an artificial intelligence based imaging, which gives us a lot more information because CT perfusion and sometimes the MR are not very well read, and the radiologist in the middle of the night may not give you the information immediately. Whereas this rapid AI automatically identifies a large vessel occlusion, and it also measures the aspect score. It is very fast and accurate and notifies of LVO. If there is an LVO, it comes through an app on your phone, and then it tells you that there is an LVO. There is a red color symbol that comes, and it projects that there is an LVO, and the message is transmitted to all the team members, and everybody are alerted. And even the advanced CT perfusion image analysis are done within minutes. From the time the imaging is done, less than 5 minutes, we get all the information, and the image is clear, detailed, and it gives you a categorical number as well. It gives you the volume that is infarcted, the volume mismatch that you have, and which patient will benefit with mechanical thrombectomy. All those informations are given by this rapid AI, which helps in talking to the patients and their family in a very categorical way and telling them that this patient will benefit with mechanical thrombectomy. So as far as mechanical thrombectomy for acute ischemic stroke, where do we stand now? The treatment of acute ischemic stroke. We give intravenous thrombolysis up to 4.5 hours. There are some publications which say that beyond 4.5 hours as well, it is useful. But as per the standard, it's about first 4.5 hours. Mechanical thrombectomy is ideally given done within the first 6 to 8 hours. And it can be extended up to 24 hours in selected patients, as I have told you, with advanced imaging like the perfusion scan. So today we have moved from just time window, being with the time, to tissue window. Based on the perfusion imaging, amount of tissue that is dead versus the amount of tissue that is viable, we make decisions. So we have moved from time window to tissue window today. As far as the treatment of acute ischemic stroke is concerned, we have come a long way from intravenous thrombolysis to intraarterial thrombolysis, which we don't do anymore. Practically, it was used quite extensively. Then to mechanical thrombectomy, and the window has been extended up to 24 hours today for selected patients. We also do thrombectomy for medium vessel occlusions. Though some trials have become negative for MEVOs, in selected cases, especially in left hemisphere, MEVO are being treated with mechanical thrombectomy, and we do it routinely. And endovascular therapy for large core have also been published in large series from North America, Canada, and Japan. And they have shown that these patients over 3 months do much better than patients who did not have endovascular therapy. And very rarely we do thrombectomy beyond 24 hours in patients who still have a viable penumbra which can be salvaged. So we have come a long way in terms of treating acute ischemic stroke. Let me just take you briefly through it. Mechanical thrombectomy is a procedure wherein we put a catheter in the groin and then we go inside the blood vessel and all the way up to the brain where the clot is, and then we remove the clot. This idea has been there for many years, but we didn't have dedicated device. Initially, devices like Mercy device, then Penumbra device came into market, but the game changer has been the Stent Retriever. This stent is actually a nitronol-based stent, which is attached to your introducer and it does not get dislodged. You put the Stent Retriever, the clot gets imbibed into it over a period of 5 to 7 minutes, and then you can remove the Stent Retriever along with the clot. This is how it works. I'll just show you a short video of how it works. You can see put the wire, the microcatheter. This is a clot sitting in the MCA. The Stent Retriever is deployed. It's a nitronol based. With the body temperature, it expands. As it expands, it cuts through the clot and grabs the clot. You arrest the flow in the carotid by inflating the balloon and then do a gentle thrombectomy to remove the clot. So this is the concept of Stent Retriever thrombectomy. I'll just show you an example. This is a 74-year-old male with a hypertension, dyslipidemia, MI 8 years ago, had coronary stent placement on Plavix found on at about 8:30 a.m. In the ER, he had right MCA syndrome with AIS stroke scale of 18. CT was done. IV TPA was given, and then the patient was shifted to the cath lab. There was still an occlusion. Patient did not clinically improve. So this is the initial angiogram. The Stent Retriever, you can see it's radio opaque and it's visible. It is deployed across the MCA, and mechanical thrombectomy has been done with a good opening of the vessel, and the patient made a good clinical recovery. And we do it in quick time. These patients make wonderful clinical recovery. The other technique we use is a direct aspiration. Is a technique wherein we put a catheter across the clot. You can see here, this is a green one, is aspiration catheter. We put it at the clot and apply direct aspiration through a pump, and it grabs the clot and pulls it out. And this is a very effective technique, and it is very fast and quick. For example, this patient at 6:01 a.m., we did the initial angiogram. There is an M1 occlusion. We take the catheter. These catheters are very soft and supple, and they traverse through even this kind of tortuosity as we see here. And we'll be able to reach the clot in less than, say, 15-20 minutes. And this particular patient, you can see thrombectomy was done within about 25 minutes. So direct aspiration is a very effective technique. So today we do direct aspiration. If it doesn't work, we combine the direct aspiration with Stent Retriever. This is a 63-year-old male with a hypertension, diabetes, and AFib. Last on well about 4 p.m. in the evening. Reached the hospital in 1.5 hours time. 2.5 hours time, and the symptoms are lethargy, disconjugate gaze, and mild quadriparesis. AIS stroke scale initially was 14. In 30 minutes on arrival into the ED, patient became worse and patient had to be intubated. And the initial CT was normal, and the CT angiogram showed a basilar occlusion. Posterior circulation stroke behaves so differently, and they present clinically also differently. And this patient, we did a mechanical thrombectomy. And this is before and after thrombectomy. You can see the vessel is completely opened up. And just to show you how this aspiration catheter works, you can see the aspiration catheter climbing up. We put it all the way up. We take it up to the clot, and we do a direct aspiration. See, and once we take out the clot, the vessel will be reperfused. This patient made a dramatic clinical recovery. In about 2 days, he was extubated, and in a week's time, he was discharged from the hospital. And in a month's time, he came back with clinically intact and doing all his routine activities without any neurologic deficit. So this is a kind of a change we can make for these patients when we do direct aspiration. So it leads to faster recanalization. Moving on, what has changed is, apart from the large vessel that we do thrombectomy routinely, we also do thrombectomy for more smaller vessels like M2, M3, A2, A3 as well. This has been like in vogue for like last 5 to 6 years, but there were some trials which were negative. So today we do select patients, particularly the ones who will benefit, especially the left hemisphere ones, even with a small area of infarct, they can have significant speech deficit and they can have comprehension defects. So these are the patients whom we select. And today, to support the mechanical thrombectomy for medium and small vessels, longer microcatheters, low profile microcatheters, low profile aspiration, and stent retrievers have all come into the market. You can see we used to have 4 and 6. Today we have 3 size stent retrievers. We have longer microcatheters. We have aspiration catheters, which are low profile, like 3 max and 4 max, which are available for us to do this medium vessel occlusions. Just to show you, this is a stent. There is a sectoral defect. You can see here, there is an occlusion of M2, M3 branch. We are going all the way up, putting a stent retriever and pulling the clot out to achieve complete recanalization. So this is all possible, but yeah, it has to be done by experienced person in a controlled situation. Otherwise, the risk of rupture of the brain vessel is significantly higher with this medium vessel occlusions. This is another case where a direct aspiration was done. You can see there was an occlusion here. After recanalization, the flow is better. Direct aspiration with a 3 max catheter was done. And then moving on, in patients with large vessel occlusion, but they present with the low NIH stroke scale. For patients who have very good collateral network, that is leptomeningeal collaterals, their NIH stroke scale will be small. Should we have to intervene on them or do not intervene? It's a $1 million question, and we don't have an answer even as of today. These patients have to be analyzed properly, and we need to make judicious judgment on whether this patient needs intervention. If needed, at what point of time does he need intervention? If we don't intervene, we have to keep them under close monitoring and observation. Early intervention carries the risk of hemorrhagic complication, and late intervention beyond 24 hours as well carries certain amount of risk as well. So in these patients, what we do is a polyphasic CT angiogram, which is quite useful, or an MRI, which is also useful. This polyphasic CT, the upper picture shows a good collaterals. You can see here, good collaterals. This patient presenting with the low NIH stroke scale, I would just sit tight, wait and watch in the neuro ICU, and make sure that if he deteriorates, that I'm able to take him up for thrombectomy. This intermediate collaterals are borderline cases. Again, I would wait and watch, but these are the patients with poor collaterals, very poor collaterals, as you can see here on the right hemisphere. Hardly any flow, even in the late phases. These are the patients I would go for early intervention, even if their NIH stroke scale is low. CT perfusion also helps us in making those decisions, and we make those decisions based on the mean transit time and the clinical presentation of the patient. Again, the MRI also is helpful in making such decisions. Just to show you a few examples, a 73-year-old patient with a diabetes, systemic hypertension, sudden onset dysphagia at about 5 p.m. Evaluation at 7 p.m. at an outside hospital showed that there is an M1 cutoff here, M1 cutoff, but the infarct load is small. Patient present with a low NIH stroke scale as well. The infarct load is only in the occipital region. The patient initially was managed conservatively, and the patient was transferred to us. And patient remained clinically stable for a few hours, and then we decided to observe. Okay, he has been okay overnight, so we thought we would observe. By evening, the patient became aphasic with the right side power of 0/5. We repeated the MRI. The MRI showed the infarct is expanding, and there are multiple small infarcts which are happening. These are classic signs of failure of the collaterals, and when these collaterals fail, this is how they present. So we went ahead, did an angiogram, and then we found that the M1 is occluded on the left side. So we went ahead and did a thrombectomy. These are the collateral networks from PCA and other vessels. Here is a stent retriever, which is placed in the MCA. As you can see here, we did a thrombectomy, and this is after thrombectomy. The vessel is open and reperfusion is achieved, and the patient recovered well. Over the next 48 hours, his power from 0 came to 3/5, and subsequently he made a fairly good recovery with the MRS of 1 at about 3 months. So these are the patients. Even though the collaterals looks kind of okay, they can deteriorate. If they deteriorate, if you intervene immediately, as soon as they deteriorate, they do recover well. So these patients has to be kept under close monitoring. So there is not enough evidence to suggest early endovascular therapy with the low NIH stroke scale, but a subset of patients will benefit with early endovascular therapy. And identification of the subset is a difficult proposition. Doing a DSA there is no evidence to doing DSA in all these patients, but we try to do it with a non-invasive imaging, either with the CT angiogram or a perfusion image, either with the CT perfusion or MRI. As on date was watchful observation and intervention in case the patient develops further progressive neurologic deficit. Another paradigm of acute ischemic stroke that we are looking at is mechanical thrombectomy in large core infarct. When there is a large core, your initial aspect score goes down to less than 6. That is when the core is seen to be larger. How is the large core involved in the trials? Mr. Clean trial involved aspects of 0 to 10, and the first Hermes multicenter analysis showed that in patients with 0 to 5 aspect score, which is a lower aspect score, only limited number of patients were included in all the studies. So we had limited insights into the whole process. But combining all the trials, it has shown that patients between an aspects of 3 and 5, which is a large core infarct, MRI is more accurate in evaluating these patients. And if you do thrombectomy, there is a favorable outcome, though there is a relatively increased rate of intracerebral hemorrhage and reperfusion hemorrhage. I'll just show you an example. A 44-year-old male, hypothyroid dyslipidemia, sudden onset weakness, inability to speak, last known normal at about 4 p.m. He arrived in the ER at about 3:30 p.m. Initial evaluation at 3:30, the GCS was E4 and M5, people's equal and reacting. He had a facial palsy with a right-sided weakness power of 0/5. So this is the patient. We know that the infarct core, you can see the perfusion image, it is kind of well established, but the perfusion image was much larger. You can see here. The perfusion deficit was much larger than the infarcted core. So we thought this patient, we can give it a try because he was a young patient presenting with a stroke. We have nothing to lose here. So we took the patient to the cath lab. This was the clot sitting in the M1. You can see here with reduced perfusion, and there are additional clots sitting in M2 and M3. So we went ahead, did a thrombectomy, did a mechanical thrombectomy to remove the clot from the proximal segment as well as the distal segment. And this was the post-thrombectomy image. You can see here there is a good perfusion achieved in the MCA, both proximally as well as distally, with good perfusion. The patient did not develop any reperfusion hemorrhage and made clinical recovery. He came to power of about 3/5, and such is the kind of change we can make even in large core infarcts. So today, the concept has changed. Even in aspects of 3 to 5, it is not a true exclusion, but the recommendation is from all the studies is that you have to try once or twice. You can't be flocking like an acute stroke treatment that you do within the first 6 hours. In patients with a large core infarct, try once or twice and try to remove the clot. And if it is very simple and straightforward, they really do well. For patients where you try more, the outcome has not been great. So there is a question of validity in terms of functional impact of reperfusion injury is what we fear when we open into a large core. But the studies have shown that no increase in the symptomatic ICH, but our experience is that there is a marginal increase in symptomatic ICH in these patients, and we have to be wary of it. We need to prime the family. We need to tell the family that though there is an increased risk of symptomatic hemorrhage, it is worth trying it, and the 90-day outcome has always been good in these patients, and the number needed to treat is only 5. It is cost effective because these patients without this treatment would have been disabled for the rest of their life. And attempts should be not more than 2. With the higher attempts, symptomatic ICH is relatively higher. And overall, it reduces the morbidity and mortality. So the next concept I want to tell here is even in large core infarcts, we can do thrombectomy in selected cases. Then acute stenting in the acute situation, a patient presenting with an acute stroke, MCA or carotid stenting, we do very rarely, not routinely. We try to avoid it because most of them are not given antiplatelets adequately. So in certain situations, we are forced to do it. For example, this patient has a significant stenosis of the left carotid at the level of the origin. The cross flow is fairly good, but the patient had clinical symptoms, significant clinical symptoms. So we were forced to do a carotid stenting in this patient, and the patient did well. Sometimes we have tandem occlusions where we do salvage stenting. For example, this patient had a right carotid artery occlusion at the origin level, you can see here. And there is a fairly decent collaterals, but the patient present with a complete hemiplegia. So we thought we will go through, and then we did an initial angioplasty, went in through the ICA, went to the MCA, and did a thrombectomy. We have opened up the MCA, which was blocked initially. The MCA, you can see there is a distal MCA block. We are doing a thrombectomy. This was a clot that was removed. You can see we have removed the clot quite well. But the proximal occlusion was quite significant. You can see here the proximal occlusion was quite significant. So we stented in the acute situation, giving antiplatelets. We give aspirin through the Ryle's tube, and then subsequently we continue with GP2B3A inhibitor for about 24 to 48 hours, and then switch the patient to dual antiplatelets. And by this way, we can salvage these patients. But this kind of acute stenting cannot be done in patients who have a large core infarcts. In patients where aspect score is much higher are the patients who will benefit with acute stenting. Then apart from the acute diseases like the heart, we have started doing a lot of intracranial atherosclerotic disease treatment. India, China, and other Asian countries are the hub where the incidence of diabetes mellitus is high, the incidence of hypertension and the metabolic syndromes are high, intracranial atherosclerotic diseases are much higher. So we need to understand which are these patients who we treat with the stenting. For ICAD, even today, medical management is the preferred method. In spite of medical management, if the patient has symptoms, patient had 2 strokes, in spite of medical management, in selected cases, revascularization procedures is preferred. And among the revascularization procedure, endovascular revascularization is the preferred method. What are the treatment options for ICAD? One is balloon angioplasty, wherein we put a balloon and just do a gentle submaximal angioplasty. We don't dilate up to the vessel, we just do an angioplasty. Second is a self-expanding stent. And the third is a balloon-mounted stent. Balloon-mounted stent, like the cardiac stent, we use rarely, but most of the time we do a self-expanding stent. Balloon angioplasty is done with a semi-compliant balloon, and today we also have a drug-eluting balloons which elute drugs into the plaque as well as the endothelium and prevent recurrence of the atherosclerotic disease. So after balloon angioplasty, if the vessel doesn't stay open, then we try to put a self-expanding stent in the intracranial circulation. Wingspan stent system was the old stent system, but today mostly we use what is called a credo stent system with the neurospeed balloon. We sometimes use other stents like Atlas and Enterprise stents as well. These are self-expanding stents which are much safer when we put it in the intracranial circulation. The others like balloon-mounted stents. Balloon-mounted stents are much stiffer stents, harder stents, predominantly the cardiac stents. We use it in the internal carotid artery up to the cavernous segment, and they work wonderfully well if they are able to be tracked to the position where we want to deploy the stents. And bioreabsorbable stents are being popularized today, but they have not come into the market for clinical use. When we have an acute stroke and the patient we think is having an atherosclerotic disease, see, acute stroke is not always embolic. There is a portion of stroke which is due to the primary disease of the vessel, like the middle cerebral artery, having a plaque rupture, like in cardiac situation, can have a stroke. And in that situation, we need to remove the clot. If we remove the clot and the vessel closes down again, which means additional clot is forming in that location, we cannot leave it like that. In that situation, what do? Can we do rescue stenting? The first thing we do is we do GP2B3A inhibitors. We try to infuse GP2B3A inhibitors like Fleta or abscessimab. If it helps us in preventing further clot formation, that is well and good. If it doesn't work, we try balloon angioplasty alone. We just try the balloon angioplasty and see if it works, but it has to be done very cautiously because we know that this plaque is an acutely ruptured plaque and the vessel may be diseased and the vessel is not as strong as a cardiac stent. So we'll have to be careful. And as a final measure, if we don't have any response and the vessel keeps occluding again, we put our stent retriever and wait for about 20 minutes and see if it stays open. Then we load the patients with antiplatelets and GP2B3A inhibitors and do intracranial rescue stenting, which is very rare. In 1 in 100 cases, we do intracranial rescue stenting, but that is a good technique to have because without that, the patient would end up with significant neurologic deficit. This patient with the basilar occlusion, You can see at the top of the basilar, we cross the lesion and then do a run, and we do a thrombectomy. After thrombectomy, you can see there is a severe narrowing. The vessel is open for a short time, and then we wait for about 15 to 20 minutes. It occludes again. So in these situations, we try GP2B3 inhibitors. We try to do a balloonplasty. Even with that, if it doesn't stay open, then we do intracranial rescue stenting. This is after the rescue stenting, the vessel has stayed open. Very rarely, in certain situations where the right and the left internal carotid artery both are occluded, and the patient is developing progressive neurologic deficit due to collateral failure, like this small infarcts progressing to acute, clinical deterioration, and the cross circulation from the posterior circulation is not good enough. We have no other choice. We don't have any endovascular therapy in this situation. In these situations, we have to do an ECIC bypass to salvage. Here we have done a ECIC bypass into the MCA territory because both the ICAs are occluded. We did it on one side and the other side was fairly holding on well. The collaterals were good, but this side the collaterals were not good. So we did only on the left side, and subsequently the patient's further stroke was averted and the patient did well. So overall, in acute ischemic stroke, we have come a long way. The landscape in the treatment is constantly changing. And today we have moved on from time window to tissue window, and imaging provides a pivotal role in case selection. Imaging is extremely important. You should have the capability to do CT angio, CT perfusion, and MRI images. And endovascular therapy has evolved from just doing thrombectomy to medium vessel occlusion thrombectomy and large core infarct thrombectomy as well. And very rarely we do rescue carotid and intracranial stenting to salvage the vessel. Thank you all for your patient listening.
Thank you, Dr. Srinivasan Parameswaran sir.
It was a very great lecture by Dr. AVS sir and Dr. Srinivasan sir. Thanks for spending more than 2 hours with us, educating all our neuroscience formal participation people. I think we reached somewhere about 160 members participating in the webinar. Definitely what Dr. AVS sir has enlightened us on a common problem, but difficult to diagnose and difficult to treat, to understand, would have given a lot of inputs for each and every participant to practice in their regular practice. And it was a great combination of intervention and surgical modalities and knowledge of acute stroke management shared by Dr. Srinivasan. Both are eminent in their profession, and thanks for spending so much of time with us. Neurosciences Forum actually is being done for educating this kind of information at a slow and steady pace from their home to have and learn, mainly for the practitioners and the postgraduates. Thanks for sharing your information, sir.
Thank you, sir. Thank you.
Thank you, sir. It was pleasure presenting. Thank you so much.
And thank you, East West
sir.
Pharma, to help us to
Thank
do
you.
this.
Thank you, sir.
Thank you once again. Thank you, one and all who participated in this event.
Thank you, sir.
Thank you. Good night.
Thank you and good night, Rajesh Babu, sir.
Good night.